Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Wait.
I am Justin Burt, joined tonight by Dr. Chris the Chu Manchu and our wonderful first-time producer, Dr. Tess Curran. Say hi, Tess.
Hello.
Welcome to the show. We are excited to have you for round one, and I think it went well. How does it feel to be an official Cribsider?
It's a true honor.
True honor.
We are lucky to have you. You crushed the episode. A great guest, a great script. Tonight we are joined by Dr. John Levin to discuss bronchopulmonary dysplasia. But before we do that, Chris, tell us about the show.
Yes, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Jonathan Levin. He's a neonatologist and a pediatric pulmonologist at Boston Children's Hospital. He's also an instructor at Harvard Medical School. He's one of the guideline authors of the American Thoracic Society's Clinical Practice Guidelines for Outpatient Respiratory Management of Infants, Children, and Adolescents with Post-Prematurity Respiratory Disease. He provides longitudinal care to babies born preterm from the time they're in the NICU through discharge and into childhood, and he particularly focuses on respiratory and breathing complications of prematurity. He teaches us about the multiple phenotypes of BPD, the evidence for and against many different neonatal ICU treatments, and how to approach these patients as they age in a primary care setting.
So we'll go ahead and get started. So today we are welcoming Dr. Jonathan Levin to the Cribsiders. Very excited to have you. Dr. Levin, welcome to the show.
Thanks so much, Justin and Chris and Tess. It's really wonderful to be here.
We are excited to have you. We're an informal, fun group, and so we asked before the show if it's okay to call you John, so we'll stick with that going forward if that works for you. And we would love to know you a little bit better. Do you mind telling us a little bit about yourself, maybe in a one-liner, maybe something including that you have an interest in that's outside of medicine?
Sure. So in medicine, I took a bit of a unusual path. Some might say a slightly masochistic path. I'm a dual-trained neonatologist and pediatric pulmonologist, and I work at Boston Children's Hospital along with Tess. And I have a specific interest in lung diseases of prematurity, which includes bronchopulmonary dysplasia and BPD. So I've always been interested in how to prevent them in the NICU, how we care for these babies and families in the NICU. And then I think the really fun part of what I get to do is I actually partake in their long-term and longitudinal care, even beyond discharge for these infants and families. And that's what led me to do the dual training. Outside of medicine, I have two young kids, 4 and 21 months, or completely a handful, but a ton of fun. And they adore each other, which is quite sweet most of the time, 90% of the time. I'm an avid runner. And despite being in Boston and doing all my training in Boston, I grew up in New York. So I am a lifelong Yankee fan, and that has not changed despite me moving roots up to Boston.
That's nice. Awesome. You're like the Peds Pulm Crit, like the adult version of the Pulm Crit combo. That's great. And we don't really have any baseball elite. I guess I was an Orioles fan, if anything. So they have never been any threat to the Red Sox or the Yankees. So they kind of just fall to the bottom.
One of my favorite ballparks, though, I will say.
Beautiful park.
Now, John, you said you're a runner and you're in Boston. Have you ever run the Boston Marathon?
No, I when I say avid runner, I mean like 3-4 miles, to be clear. But we live right by the marathon, actually. It was just a few weeks ago, and we took the kids to watch it, so they had a blast.
Nice. Is there anything recently in pop culture that you've just enjoyed recently that you want to share with the rest of our listeners?
All right, this is my nerdiness coming out, but I've always been a big Star Trek fan. Like, grew up with Dad watching a ton. So I was watching, what is it? It's Star Trek Discovery, and I just watched the last episode last week, and I was just blown away. Sorry for spoilers. I should maybe a warning, but I was blown away from the fact that Stacey Abrams, the politician, came in to play the president of Earth in the last episode. I thought was absolutely hilarious.
Oh, whoa!
That's amazing.
What a cameo!
Seriously,
that's amazing. That's cool. We'll put a link in the show notes.
I'm excited about the Christopher Pike episodes. I think a couple of them already come out. I just haven't gotten a chance to catch up, but I'm excited about those.
Neither have I. I was too busy preparing for this podcast.
Did you guys see? There's a New York Times crossword puzzle not that long ago where it said 8-letter word for the best sci-fi series, and it worked both Star Wars or Star Trek, depending on how you filled out the crossword.
Amazing.
They're smart people.
That's definitely purposeful.
Yeah. All right, so let's dive into some content. Chris and I always get nervous around babies, specifically patients who are babies, specifically babies who are patients in the neonatal ICU, because it's been a while for both of us. And so this is going to be a great review for us, but I think a lot of very helpful stuff that would have been helpful for me in the NICU as a resident in training. And to your point, Jonathan, I think we see a lot of kids that have chronic lung disease from infancy. And so excited to get into this. And so we'll go ahead and get started back in the NICU, throwback to residency. And we're going to say that we're the listener, a pediatric resident in the neonatal ICU, called to an emergent delivery of a 28-weeker. Mom's a 35-year-old G2P1. She had a high-risk pregnancy because of gestational diabetes and preeclampsia. She was ultimately administered magnesium sulfate and dexamethasone prior to delivery. The infant is delivered via vaginal delivery due to preterm uterine contractions, and APGARs are only 4 and 6 at 1 and 5 minutes, respectively. Given some persistent desaturation, some irregular respirations, the kiddo is placed on positive pressure ventilation and rapidly transferred to the ICU to us for further intervention. And so, unfortunately, common, I think, scenario in a premature child. But talking about this concept of bronchopulmonary dysplasia or chronic lung disease in infancy, can you walk us through what is BPD? What is the definition? What is this underlying pathophysiology of these types of patients?
So let me start why it's so important to talk about BPD. So, first of all, prematurity, about, depending on the year and the estimates, like 10 to 11% of babies are born preterm in the U.S. And obviously a smaller subset of that are the extreme preterm infants, which are at highest risk for a number of adverse outcomes of prematurity. And in fact, if anything, prematurity rates are probably slightly going up. That might be having to do with more complex maternal medical conditions or mothers who are pregnant who have more medical conditions. That being said, a lot of our outcomes in neonatology have improved over time. The care has gotten better, more advanced. The one that hasn't is BPD. So that's actually, if you look at the numbers of prematurity and you look at these outcomes, everything has a sort of the right direction, and BPD is totally stable. Like, we haven't really made a dent in the rates of BPD. So there's about 10,000 kids a year probably who are being born and end up getting BPD. And it's the most common complication of prematurity. Thinking about like pediatric pulmonary conditions, so it's probably the second most common after asthma, the second most common condition that present to pulmonary specialists. So there's a lot of kids who are affected by BPD. So what happens in these kids? The way I describe it, it is BPD starts with an arrest of lung development. And you might remember from med school embryology, probably not remember from med school embryology. There's these different stages of lung development. We all have like mnemonics that we can remember them. Every pulmonologist can see alveoli, embryonic, pseudoglandular, canalicular, saccular, alveolar stage. So basically, you have these infants who are being born at kind of that middle of lung development. And while respiratory distress syndrome, kind of what you were describing in this case that this kid's likely going to have, is largely due to surfactant deficiency. Even kind of when you get past that phase, these kids have lungs that are just underdeveloped. The alveoli are there's fewer of them, they're more simplified, they're kind of thinner. And then on top of that, they're getting exposed to oxygen in the NICU, ventilators, other inflammatory things like infections, and that impacts the lung development too. So it's true that, between antenatal steroids, surfactant therapy, we've kind of made a lot of advances in neonatology. Those really haven't impacted the rates of BPD, just because it is ultimately when these infants are born early, their lung development is arrested at that early age.
And can I ask, there's a lot of terminology that I feel like always falls into the one-liner of the NICU. It's, BPD, chronic lung disease, surfactant deficiency. Are these all describing kind of the same process, or is BPD a preferred terminology?
Yeah, so you can think of BPD as like a later outcome of infants with RDS, with surfactant deficiency. So it's kind of describes the later process. Technically, we don't make the diagnosis until they're about 36 weeks post-menstrual age of officially a BPD. And there's a lot of, there's a number of definitions that exist out there for BPD, which is also one of the confusing parts of it. But even so, I think you'll see a lot of like evolving chronic lung disease in the NICU. And those are the kids, even if they're not at 36 weeks, you still know that they have significant lung disease and are likely headed that direction.
And one thing that our wonderful producer, Dr. Tess Turan, has pointed out that I kind of did a little more reading about because I hadn't seen these terms, but there's some terminologies of old BPD versus new BPD. Can you talk a little bit about that? What's this old versus new BPD?
Yeah, so when BPD was first described, it was in the 1960s, and as you can imagine, neonatology was a vastly different field at that point. So when it was first described, you were talking about infants who were born, like I think the mean gestational age in the first paper, it was Bill Northway that described it, was like 34 weeks, right? And that's going to be very different than the experience today. I mean, for a 34-weeker to end up with BPD would be incredibly uncommon these days. So, I think old BPD really reflects chronic changes, fibrosis, inflammation that was due to prolonged oxygen exposure, prolonged ventilation, while new BPD is more of that developmental arrest. It's sort of these lungs, if you can imagine, they're just, if you were to do a biopsy of them, not that we routinely do that, but if we were to do a biopsy of them, they would just be very simplified. If you think back to like your med school histology, it's the alveoli are just fewer, they're thinner, the vessels are fewer and thinner also, and probably somewhat dysmorphic, and that describes more new BPD.
And is there a scale of, I'll give you this one, Chris, I'm sorry. Is there a scale of severity of the disease, a grading system, or some other measure of how bad is this child's BPD, or how bad is this child's chronic lung disease or surfactant deficiency?
Yeah, so the most common one that I think people still use is the mild, moderate, severe definition. It comes from actually 2001, so it's over 20 years old, and it was really just a consensus workshop. I'll say it's BPD is it's an odd disease with definition in that it's defined and the severity is defined by the treatment you're using for the disease, which is the amount of oxygen you have to give to the baby. So, classically using that 2001 definition, mild BPD are kids who require support or oxygen for 28 days at first, and then are off all support at 36 weeks. Moderate, more or less, are kids on oxygen therapy at 36 weeks. And severe is going to be kids who require some kind of either non-invasive or invasive ventilation at 36 weeks. And this is among under 32 weekers, and there's kind of a modified definition if you're above 32 weeks of your original gestational age. That's actually been revised a few times since then. So I think there are probably newer definitions that are somewhat simplify that, frankly, and actually were based on looking at outcomes of the Neonatal Research Network, which is this large, consortium across the country looking at practices in neonatology and outcomes. So there's one called the Jensen definition from Eric Jensen that essentially says grade 1, 2, 3. That sort of simplifies it. It's grade 1 BPD if you're on a low flow cannula at 36 weeks, grade 2 if you're on high flow nasal cannula or like non-invasive, so like CPAP. And then grade 3 would be the kids who are still on positive pressure, like invasive ventilation at 36 weeks.
So since the definition is based on at the time of 36 weeks, once you get classified, you don't ever move your classification if you get better or worse. Is that correct?
It's a great question. Once you have the diagnosis at 36 weeks, that remains in your history at the very least. But one of the reasons that we love taking care of this population is that even in healthy term kids, there's ongoing lung growth and development that happens, after birth, particularly in the first 2 years of life and, likely up until age 10 or so. And that's still true in these kids who have BPD. So we really try to create this sort of pro-growth, pro-lung development environment for them that allows them to recover some of their lung function and growth during that time. So even though they might have that diagnosis of severe BPD, they'll still be on a positive trajectory, after birth.
And for our patients specifically, it seems like there were a lot of risk factors and prematurity and high-risk pregnancy and even some of the medications potentially. What are the risk factors for someone for developing chronic lung disease or BPD, and why might one premature child develop it and not another?
Yeah, that's a great question. And it's one of those, we still don't know all the answers to this, of course. Gestational age is definitely the number one risk factor. So the lower the gestation, the higher risk of developing it. Probably in the kids who are on the really extreme premature kids under 28 weeks or so, you're going to see upwards of 80% of kids ending up with BPD. That'll go down as you kind of get closer to 32 weeks. But there's other risk factors too. So for example, kids who are born small for gestational age, or kids who mom had preeclampsia, or mom was a smoker, and that might have interfered with some of the placental blood flow. That probably impairs pulmonary growth in utero and therefore has an effect on their lung development postnatally too. Postnatally, there's a lot of risk factors too. So, it's interesting, we're talking about this infant on day one, but what's going to happen to them in the next few weeks will also modify their risks of developing BPD. So for example, kids who have infections, or maybe were born to a mother with chorioamnionitis, or had necrotizing enterocolitis or sepsis, that inflammatory environment is not good for the developing lungs, and that's going to increase their risk of BPD. Kids who are on prolonged mechanical ventilation and are going to be at highest risk for BPD, particularly kids who need it for more than 7 days of life, kids who need oxygen. And that's because there's oxygen toxicity, there's volu-trauma, which is basically overdistension of these very immature lungs, barotrauma, which is high pressure to these immature lungs. And then there's other things that, might give you some PTSD from the NICU, like PDAs, the patent ductus arteriosus. So, the ductus arteriosus, of course, is an in utero connection between the aorta and the pulmonary arteries that closes typically, but in preterm infants can stay open. And we know that there's a clear association between kids who have a PDA and developing BPD, probably because of extra blood flow to their lungs and overcirculation. But it's actually unclear if treatment improves, the outcomes of BPD. So that's kind of an interesting one. And then there's likely some genetic influence too. There's not, one gene that's like the BPD gene and puts them at risk, but there's been a number of like larger studies that have identified, some risk factors among like a large pool of genes.
Do we see any like familial like traits, like if like we like first degree relatives or anything that they've had all their other preemies in the family that they've also had BPD? Do we see any of that sort of happen?
There's probably some percentage that's relatively small. Can't quote the exact number, but it's in the 20 to 30% range. That might be kind of that genetic exposure. But, for example, I'm thinking of babies I'm taking care of now where they're identical twins, right? And one developed BPD and the other, one developed severe BPD and the other one has mild BPD. So, I think it really speaks to the fact that, their in utero growth was very different and their postnatal life was very different too.
So, John, one question we have. So you were talking about how ventilators can actually cause, maybe there's some sort of affecting cause trauma within these neonates that increase the risk for BPD. What are some of the strategies that you do with the ventilator to minimize these inflammatory effects?
Yeah, that's a great question. Ventilators are saviors in some of these micropreemies and let them survive. At the same time, they add injury to their developing lungs, so you get both sides of the coin there. The trend in neonatology over the last probably 1 to 2 decades has really been to move towards non-invasive ventilation whenever possible. So using things like CPAP or NIPPV as which is nasal intermittent positive pressure ventilation as kind of the mainstays to treat respiratory distress syndrome, to really prevent and minimize exposure on the ventilator. And even for kids on the ventilator, we really try to take a very gentle approach to ventilation. Like we let their carbon dioxide be a little bit higher than maybe you would have tipped another kid's called permissive hypercapnia. We've realized that, oxygen targets, there's a lot of questions still about, what the exact oxygen target should be, but, probably in the low 90s or so seems to be the right number for these kids. And that helps decrease some of the toxicities when you're on a ventilator too.
Excellent.
Yeah, it's true. I remember my favorite, titrating to jiggle is how we did the jet settings. I don't know if that was actually the correct vent settings, but that will never leave me.
That's still what I teach when they say, how do you choose the initial settings?
It's a titrate to jiggle.
Yeah.
Amazing.
Yeah, in all seriousness, it's a good point. And we definitely have these sort of advanced types of ventilators called high frequency ventilation, either the jet or the oscillator, kind of by common names. And there are some centers that use that kind of as a primary way of ventilating these little babies to help prevent some of the, the volume trauma and the barotrauma that I talked about before. But it's not really been something that's consistently shown in the literature as a good primary prevention strategy. And there's so I would say it's not a universal practice by any means.
I know my time in the NICU was very humbling, as I mentioned before we started, and I am excited to talk about treatment because that was one where I, sometimes there was a lack of evidence basis, or there seemed like there was some different viewpoints. I remember very specifically one anecdote where I just started. I think it was an intern, started on the weekend, and we were talking about treatment of one of these patients with chronic lung disease, specifically with diuretics. And so I'd love to talk about some of the other things, but I remember diuretics. The attending, was like, oh, we need to be diuresing. And it was like, I don't know how to do a volume exam on this 30-weeker, but I trust you. You seem much smarter than me, so we diurese. And the new attending came on and said, why are we diuresing? This is ridiculous. So we stopped. And then I think a third attending restarted. And then we had the attending, this Dr. Nogi, who was seen as like the deity around there. And it was like, he'll know what to do. And he gave this very beautiful description of the pathophysiology, which I completely forget now, to explain why in this particular child we should definitely diurese. And it was like, great, we'll start the diuretics again. And he was like, no, I'm just the weekend attending. The next attending is coming on tomorrow. Just do what they want you to do. But I would love to, that was my NICU anecdote, but I would love to hear your anecdotes of treatment of BPD, steroids, caffeine, surfactant, nitric oxide. What do we got? What's in our toolbox for these kiddos in their little lungs?
Justin, you probably just described medicine, if certainly neonatology in a nutshell. So we could probably just stop here. But I'll get to diuretics. I always actually start when we talk about treatments. There's a lot of things that certainly don't work. There's some things that are evidenced. I recently saw people describe treatments in neonatology as things that work, things that were maybe a little bit foolish to pursue, but at least weren't a bad idea, and then things that were clearly a bad idea. Things that don't work, and I'll actually start with this. So surfactant, of course, is an incredibly important medicine in neonatology and has saved countless babies worldwide. Going back to thinking about what BPD is, so surfactant does not decrease rates of BPD. It improves RDS, which we think obviously, that will minimize how much ventilator exposure these kids get, and is certainly beneficial for them, but it's never been shown to actually improve rates of BPD. And I think that's actually goes back to the fact that, again, it's a developmental arrest, right? And timing growth is probably the most important treatment, frankly, in these kids, and trying to minimize the toxicities that they get. That being said, there are some evidence-based therapies beyond that. So caffeine, you mentioned, for listeners who have not rotated through a NICU, it might sort of surprise you that we put all these preemies on caffeine. And it's actually a really interesting backstory. It was, we used to use sort of more toxic medicines like theophylline as ways to treat these babies, sort of do silly things with their breathing and just have pauses in their breathing, and the nurses run over the bedside, kind of like rub the baby's, back a bit and go save a life, as we say, and then they remember to breathe again. And they say, well, if the kids just desaturates like that, just turn up the oxygen. But you don't want to do that either, because that's not so good for their developing eyes. So there were medicines that kind of stimulate them to breathe, like theophylline, but that was like very toxic. So then they realized that caffeine was in the same medication class, the methylxanthine class, as theophylline, and actually believe it or not, carries way less toxicity. That being said, so it's one of the better trials in neonatology it's the CAP trial. So they did it, to really, like, when you're sort of hearing that story, you're like, well, that sounds okay, but is it safe to give like a premature baby caffeine? Is that going to affect their neurodevelopment? So that's really all they were trying to do, is to look and see, like, okay, at least is it safe or not? And, basically it showed, like, not only did it work, but their 18-month neurodevelopmental outcomes were better, the kids who were exposed to caffeine in this randomized trial, and they had less lung disease. They had less BPD. And that's probably because by stimulating them to breathe, it helps them wean off the ventilator. It helps them wean off helps them avoid getting extra oxygen. So caffeine is actually a sort of, in a lot of like quality improvement bundles, a mainstay at improving rates of BPD. We talked a bit before about non-invasive ventilation, and sort of using that as like a primary means of rescue for respiratory distress syndrome, and not just like intubating every baby and giving them surfactant. And that's actually been shown, like, in meta-analyses, not in any one study, but in meta-analyses to reduce rates of BPD. Not to get too in the weeds about ventilation strategies, but for those who are more interested in ICU fields, there's differences in kind of how we ventilate, whether we're targeting a volume or we're targeting a pressure. It's like pressure ventilation or volume ventilation. And in short, it seems like volume trauma is worse than barotrauma in these kids. So if we limit the amount of volume we get, so if we target a certain volume that they get and so set that as our parameters on the ventilator, that's probably a safer strategy. And again, I will say in neonatology that we have like a really strong group of Cochrane meta-analyses that kind of group all the studies together, but that's also been shown to help prevent BPD. So good nutrition is also incredibly important. Primary provision of mother's own milk, has been shown, not in large randomized trials, but, has at least observationally been shown to reduce lung disease. And then there's all the medications that we sort of think about ways to rescue kids. So you mentioned diuretics as one. Diuretics have never been shown to decrease rates of BPD. They are frequently used. I use them at times. It's not to say that we don't. But I think of it as diuretics, what it definitely gives you is it gives you this sort of short-term boost, right? The short-term improvement in compliance. And there are certainly select kids who might benefit more, like kids who have like an ASD or a VSD, something that causes them, or a PDA, something that has a little bit more overcirculation. But chronic exposure to diuretics is never, the kids adapt to them pretty quickly. It's never really been shown to reduce rates of BPD. They're still widely used. Steroids. So antenatal steroids are good. We know that. As a separate conversation is interesting. The original trials were like in the 1970s, and it wasn't widely adopted in practice until about 20 years later. So talking about implementation medicine that's a whole separate interesting conversation, but that's clearly a good thing. Postnatal steroids, so giving the kids steroids. So this interesting story here, the pendulum has swung both ways. So frankly, before our time, the high-dose steroids were pretty frequently used because they worked to get kids off the ventilator. I mean, there was clearly an inflammatory component. You gave them like big doses of dexamethasone, and then they weaned off. And then they did trials, and this goes in the category of, things that weren't so good to do. And that early exposure to dexamethasone actually was associated with higher rates of bad neurological outcomes, including cerebral palsy. So now that's like an AAP, like no-no. Like it is a guideline statement. Do not give premature infants, at least prophylactically, high doses of early dexamethasone. So then it swung the other direction, right? And everyone said, well, we clearly shouldn't be using any steroids in these kids. And that probably was too much either, especially because you're trying to basically group all these kids as the same, when in reality, there's going to be kids who are at higher risk than others for developing lung disease and even the neurologic outcomes, which tend to associate with the lung disease. There's going to be benefits for treating it. So there's been a lot more studies since then looking at kind of specific doses and types of steroids. So you have dexamethasone, you have hydrocortisone. We use some prednisolone, though that's less studied in neonates. And not a lot of studies that directly compare one to the other. It's interesting. We've had like a lot of great trials with steroids, but there's still a lot of unanswered questions. But at least the meta-analyses really sort of suggest that, and some of the recent trials that included hydrocortisone that probably do suggest that dexamethasone seems to be at least more effective than hydrocortisone at preventing BPD. And I think because of that story with dexamethasone and early exposure, we try to wait a little bit. So we typically many places will have guidelines, and this is what we do, where we wait till we kind of assess their risk of developing BPD at around 2 weeks of age, and if they're at high enough risk, then we consider the risks and benefits of using dexamethasone in particular, and a lower dose of dexamethasone than had been previously used before, and that's based on studies seems to be have at least reasonable neurologic safety and efficacy, that approach.
Was that from the DART trial? Is that the one?
Yeah. So DART's great name trial. It's actually an interesting story. So that was a trial about 15 years ago, I want to say, actually based out of Australia, that looked at low dose dexamethasone. So specifically, it's like a 10-day taper of dexamethasone, where the total dose is like 0.89 mg per kilo. So it's relative, which is a relatively low dose, and looking if it was effective. So the truth about the trial is it did seem to be, effective at reducing, getting kids off the ventilator, reducing their oxygen requirements, getting them extubated. The trial was actually stopped short because of difficulties with enrollment. So, it was, a smaller trial than I think was then originally designed. It was, I think, only about 30 to 40 kids in each group. But I think based on that, and that's kind of been adopted in both other observational trials too, that's just a commonly used protocol for steroid administration.
And I wanted to follow up too, because you mentioned mother's milk. And if I remember right, this is actually one of the indications where donated breast milk is a big high yield treatment. Is that right? Am I remembering?
So it's in the NICU. We know that donated breast milk does reduce rates of necrotizing enterocolitis. It's not as good as mother's own milk, to be clear, but as an alternative, especially there for many reasons, you have these sort of moms who are just been through like an early delivery. There's obviously lots of both medical and social stresses going on. Some, there are a number of medications that they sometimes, it's hard to produce adequate milk supply sometimes for these preterm infants. So in those cases, certainly using donor milk as a supplement is preferable to using like a preterm formula, which prevents necrotizing enterocolitis. I don't believe it's really been shown to reduce BPD per se compared to formula.
This is great. This is like recreating those synergies of neurons in my NICU department of the brain. This is wonderful. And then a couple other. Sorry, go ahead, Chris.
Oh, yeah, I was just going to say, were there other treatments that we haven't talked about that whether?
Well, yeah, you guys mentioned diuretics, which you talked about a bit. Fluid management kind of goes along with that. So you might remember, I know I promised before the podcast we wouldn't talk about total fluid, so I won't get into numbers. But we a lot of places, and it's pretty common practice, will like try to limit the amount of fluids these kids get or restrict them just to this idea of decreasing pulmonary edema. Again, that goes in the category of never been shown to be effective, potentially harmful. When I said it at the top, and it's like it's not that exciting of a treatment, but time and growth, time and good nutrition. So you don't want to do anything you certainly don't want to sacrifice calories that these kids are getting and potentially need to fluid restrict them. I think it's sort of an in-between is reasonable. We're not like giving them an excess amount of fluids, but, extreme fluid restriction that, at least commonly, and not sort of excluding the sickest kids, it probably is of little benefit. Nitric oxide, commonly used in other conditions in neonates, like, PPHN or persistent pulmonary hypertension of the newborn, like fabulous therapy, life-saving. Routine use, at least in premature babies, to prevent BPD, never been shown to be effective. Well-read listeners might have heard about vitamin A as a treatment, and this is actually goes in the category of it was shown in trials to be effective, like with a reason, like number needed to treat to prevent a case of BPD of 12, which is pretty reasonable for an intervention. But when this is like, again, going back to implementation, so what does that actually mean? These were intramuscular injections into these little preemies who have like no muscle mass to begin with, 3 times a week for a month. And you can imagine high cost, and you can imagine that it wasn't very popular in NICUs to use. And then on top of that, about 10, 15 years ago, there was a shortage, so people couldn't get it. because I think the manufacturer stopped making it. So NICUs looked at their BPD rates and they didn't change once they stopped using it. So that's actually fallen out of favor too. The thought is like with other advances in neonatology, then that might have sort of improved BPD rates with like the non-invasive ventilation thing that made vitamin A, which by the way, it's the rationale there is it helps with like some of the respiratory epithelial development. So that's not nearly as commonly used.
Very cool. So we're going to continue our journey of our child who named Bobby Peroncini. He grew up to do relatively quite well, and you're now seeing him in the Cashlack Primary Care Office. He is 4 months old now, has been diagnosed with bronchopulmonary dysplasia, and his caregiver is saying that he's got some cough and congestion that has required them to go up just a little bit on their oxygen. So he's still at about 0.2 liters only at night, but is now having to use 0.25 liters and maybe even using a little bit during the day. On exam, he does look pretty tired. He's tachypnic. He's got subcostal and intercostal retractions. On auscultations, he's got scattered wheezes, diffuse rhonchi. It's different than his baseline exam. And so we're thinking that this seems typical of a common bronchiolitis diagnosis. But in a patient that has bronchopulmonary dysplasia, what are the important discussion points for one of these kids to have a common cold or bronchiolitis, or how to really do a good exam and assess when they are sick?
So it's a great question. And actually, even to take it a step back, in terms of some of the routine counseling that we do for these families, taking these infants home, I really think it's really important to kind of teach the families almost how to do a good respiratory assessment, an exam. I don't mean like buy a stethoscope and auscultate your baby, but many of these babies will go home from the NICU with some of the things you described, frankly, like some tachypnea that's sort of more than a typical kid, or baseline subcostal retractions or intercostal retractions. It's again more than a typical kid. So I really talk to like our first visit with these families, or even before leaving the NICU, we review this and we say, when particularly when your kid is sleeping, because when kids are awake and get excited, it's always tough. It's a good practice to actually learn how to count their kid's respiratory rate and get a good sense of what their baseline retractions look like, because as you mentioned, these kids are certainly at risk when they get an upper respiratory infection or a cold for developing a lower respiratory tract either infection or bronchiolitis, really just adversely affected by these common illnesses. And it's just so important to know what's baseline and what's not baseline for their kid and when they need to seek attention. The other one we talk about is actually their feeding. So if it's an orally fed kid, that's kind of like the stress test for the baby. And so if they're noticing a big difference in their ability to eat or drink, and the work of breathing that goes around that, or symptoms after feeding, like cough or wheezing or congestion, that could also be signs of a clinical worsening.
And for these kids, we did our first episode on the Cribsiders was on the bronchiolitis guidelines, and there's very clear guidance of no real need for albuterol or steroids or X-rays. But there's very clear exclusion criteria for kids with chronic lung disease. So when these kids are in your clinic, because you're our expert continuity status post NICU provider, what is the general sense of how do you treat respiratory distress secondary to a viral infection, whether it's URI, bronchiolitis, in these kids? Do you do steroids? Do you do antibiotics, albuterol, chest X-rays? What's the toolbox?
Justin, I think you highlighted something super important there, which is all of us well-trained pediatricians really want to be cognizant of good evidence-based practice with bronchiolitis, and really supportive care, and not routine administration of these medications without efficacy that haven't been shown to be efficacious. But as you said, preterm babies are excluded. So the American Thoracic Society, ATS, actually just put out a new guideline for treatment of, they call it post-premature respiratory disease, or that's what we called it. It sort of encompasses BPD and kind of other diagnoses as well. But kind of one of the points we made in the guideline was really that you have to treat these kids differently, and that we shouldn't be using the exact same practice pathways that we use for full-term kids. Why is that? Well, first of all, their risk is higher, right? So Admittedly, it's harder to assess risk now because of, RSV prophylaxis pelivizumab, which is quite efficacious. We'll talk about that too. But at least before that, we know that, even kids who didn't have BPD. So if you're born under 32 weeks and don't have BPD, that doesn't mean you're risk-free. That's still probably like a 3-4 times higher risk of admission with bronchiolitis compared to a typical a healthy full-term baby, and BPDs can be much higher risk, probably 3 to 4 times that risk. So somewhere in the 10 to 15 times risk of a full-term baby. And that goes to show it's like when we talked about definitions earlier, and they did validation studies, of course, looking at these definitions, looking at the respiratory outcomes. When we first look at the graphs, you say, all right, well, this fits. Like the severe kids have the highest risk of readmission and rehospitalization, but even the kids who didn't have BPD and were preterm. There were some studies that were still reporting 25% needed hospitalization in the first year, and if that was your primary care panel, that would be a number that would stand out at you. So all these kids are whether or not they have a formal diagnosis of BPD based on that 36-week measure are at risk. So and it's risk of hospitalization, risk of ICU, or needing respiratory support. So on that note, we know that they start with higher risk. While there aren't great randomized trials by any means looking at albuterol, inhaled steroids, systemic steroids, in treatment for these kids when they have exacerbations. We know some information, at least based on some of the pathology that's going on. So for example, most studies, when they look at these kids and if they give them albuterol, and there's ways to measure pulmonary function actually in babies, about 50% will end up responding to albuterol, which is going to be a much higher number than a typical full-term kid. So the ATS guideline that we just put out actually states that, kids who have recurrent respiratory symptoms should have a sick plan with a beta-2 agonist or short-acting beta-2 agonist like albuterol as needed. For kids with chronic cough or recurrent wheeze, that's an indication for a trial of an inhaled corticosteroid, something like, a fluticasone or budesonide. I think, other systemic steroids, are less evidence. We know, from when this is kind of more gets into my practice, we know that these kids, again, are more likely to be albuterol responsive. So, to me, we know that they're a little bit more I always find that they're a little bit more likely than the typical full-term kid to really respond to a course of prednisolone. And again, if they're starting at higher risk, if I, hear a kid who's got a clear wheezing illness early on, I think that's going to be, likely I would try a short course of steroids in them compared to, let's say, a full-term kid. Antibiotics, I think, probably have less of a routine indication unless the kid has other comorbidities. So we have a lot of kids who have feeding difficulties and aspiration. So that's always something, you have to keep in mind, and they're more likely to get, let's say, an aspiration pneumonia.
And can I, not to get too deep in the weeds, but for a patient, as you mentioned, with BPD, where the underlying pathophysiology is a immaturity delayed growth, and maybe I'm not thinking about it, but I would be surprised that albuterol, the medication for asthma, for bronchoconstriction, for an inflammatory lung disease, would be so effective in immaturity of lung disease. Is there a clear understanding of why albuterol or even steroids can help in these cases?
It's a great question. And, when I let's say, teach Noon conference about BPD, I always show like a Venn diagram with asthma and BPD and what are the similarities and differences. Ultimately there's a degree of small area narrowing and, probable some muscle hypertrophy that can occur in both diagnoses. I think it's to less of a degree, the hyperresponsiveness, than in asthma. So for example, in asthma, sort of by definition, right, 100% of those kids should respond to albuterol. And in BPD, this goes back to the idea that there's a lot of different like BPD is kind of a catch-all phrase because it's just defined by their oxygen need at 36 weeks. But when you think about it, there's going to be a lot of different phenotypes in BPD. So, there are kids who will be more of that obstructive disease phenotype like asthma, where we think there is some more, muscle hypertrophy and hyperresponsiveness and are likely to respond to albuterol. But you're right, there are probably some kids who just have small airways, frankly, and they get plugged up with mucus, and maybe you get like a small transient effect from the albuterol, but, it's more of a fixed obstruction. And in fact, we see that even in the older kids when we do pulmonary function, that it's sort of, this interesting idea that a lot of kids with BPD end up with asthma diagnoses later on. Whether some of them certainly do have asthma. I mean, it's obviously a common condition, and there are probably some environmental comorbidities that put them at risk for both. There's also, I think we're calling kids who have asthma who probably more have like a fixed obstruction, not to get out of our pediatric world, but maybe even more like a COPD like disease compared to asthma. Yeah, so I always say BPD is probably more like the COPD of pediatrics than sometimes asthma is. Much like COPD, there's variable response to bronchodilators, but certainly I would say more likely than the typical full term kid.
Now, we've just talked about like how we're sort of treating these patients, and you said that pavlizumab has really changed how a lot of these kids have responded. Can you talk a little bit about pavlizumab, and are they all should they all get immunoprophylaxis with this? And maybe we can even talk about other vaccines as well.
Yeah, pavlizumab is indicated for prophylaxis against RSV infection in these babies. So first of all, it is not a vaccine. It is immune prophylaxis. So it is a monoclonal antibody that's anti-RSV. Therefore, it is passive immunity, right? Meaning that you have to give it basically every month during the RSV season. Doesn't teach the kid's immune system anything. So there's actually pretty strict guidelines that the AAP put out on this, which we do follow. I'll kind of give you kind of from my experience where I see it like on kids under 29 weeks, born under 29 weeks. Are in the AP guideline, whether they have BPD or not, or if they're under a year of age, for their first RSV season, essentially. So if they're under a year of age at the start of their first RSV season at home, which kind of varies depending where you are in the country, what that is. But, here in the Northeast, it's more or less October, November. That's an indication for pavlizumab. So under 29 weeks. I find when I see kids like, pediatricians are fabulous at recognizing this, right? That's like, it's incredibly rare that I'll see a kid in pulmonary clinic and that the pediatrician hasn't already applied for pavlizumab. And frankly, many of these kids get their first dose on the way out of the NICU, since we know that the highest risk period is when they first go home. So you want that coverage really for the first month when they go home. Then there's another category, speaking about preemies and lung disease, that's babies under 32 weeks who have CLD, and the AAP guidelines do define CLD, so it's support for oxygen support for 28 days in the NICU. And, I think this can be sometimes a miscategory. Again, this is for the first winter at home. So that's a case where it's per AAP guidelines, the insurance company should cover this, to be clear, but it's the case that not everyone thinks about because it doesn't meet that under 29 week cutoffs. And then kind of it's beyond the scope of this conversation, but there are other indications just worth mentioning, like, certain classes of congenital heart defects and disease, certain neuromuscular conditions as well. The other case where so then that comes into play is the second winter. So there are some infants that actually qualify for pavlizumab prophylaxis in their second winter. I think this is one where, again, most people don't think about it as much because you need to know the specific indications. So for kids who require respiratory support, so whether it's kids who are tracheostomy and ventilated or they're on oxygen therapy, within 6 months of the start of that second RSV season, they'll qualify for pavlizumab prophylaxis that second winter. That might sometimes require a letter explaining why that is to the insurance company, but again, they should approve it. It is within the guidelines. And then the other one is actually for kids who are on chronic therapy going into the second winter for BPD. So we've had a lot of success at getting coverage, for example, with kids on inhaled corticosteroids, because they have recurrent respiratory symptoms, and getting coverage for the second winter as well. We talked about kind of the categories, and I think the clear thing is that the evidence is pretty good that pavlizumab reduces the risk of RSV hospitalization. It reduces the risk of ICU hospitalization with RSV. There was this sort of like question of could that actually change the ultimate outcomes, right? If these kids are getting less sick, like might they actually have this better period in the first 2 years than when they're 5 and 6 years old and running around playing soccer? Are they going to do better? Unfortunately, the data hasn't shown that, so it doesn't look like it really modifies the overall trajectory. But that being said, there's plenty of worth if you can keep these kids out of the hospital and decrease ICU hospitalizations. So
a little side note, I think we're talking about RSV and other viruses. we are now in a post-COVID world. What does BPD look like in this world? Like, I know we don't have a lot of studies, especially in BPD for this, but like, do we see something like Paxlovid coming down the road for BPD patients? What does it look like, and how should we approach our patients during this time period?
Yeah, let's start with the non-COVID illnesses first. So I think one of the tricky things that we've had to navigate in the last 2 years is how other viruses have been very unpredictable in terms of the viral seasons in virology. So for example, if you looked at least locally, I know this, if you looked at in March 2020, our RSV positivity rate like plummeted to 0 almost instantaneously. And it stayed like that for basically the entire next winter. Also, we was this debate of like, do we give the kids their palivizumab? We did, because we didn't want them to get hospitalized for that. But it was very low, very, very low rates of RSV bronchiolitis, as you guys are probably well aware, in that 2020 to 21 winter. And then in this, depending where you were in the U.S., for the Northeast, it was kind of late summer. Earlier in other places, we had this like very early peak of RSV. So we actually started kids this past winter with their palivizumab prophylaxis. It was late summer, early fall. And again, that was something that the AAP had put out a recommendation, non-specific, but basically saying, you should consider starting it earlier, and if so, insurance companies should cover it. And then, state guidelines, particularly for kids who are state insured, we're kind of quick to cover it, which was helpful. And they ended up getting this extended course of many of them for palivizumab, because we didn't really know what the season was going to look like, right? I mean, even I would argue 2 months ago, I wasn't sure whether there was going to be RSV now or not, right? And there is some, because particularly with, mask wearing is incredibly effective against spread of RSV. So, and the same goes for flu. We're sort of seeing sort of atypical flu season. So, I'm not a virologist by any means, but and nor do I pretend to have the crystal ball to know what these future seasons will look like. But I think just there's roles for humility and following positivity trends, and being on top of it and being flexible about this when we're starting RSV season or ending RSV season for that matter, and kind of when we start their prophylaxis. And I'll be curious to see what happens going forward, especially as society somewhat tries to normalize around the pandemic. As far as COVID-19 in particular, illness in patients with BPD, we have very limited data still on this. So let me start with that and say, like, this is kind of my own experience of what I've been counseling families, because of course it comes up as a question. And I think there's a few different risks. So first of all, little babies, at least some of the initial studies, with the earlier strains of COVID, definitely suggested higher hospitalization rates with younger infants. Some of that may have been a little bit kind of cautious medicine, I guess, because the ICU hospitalization rates weren't overly high. It was just general hospitalization rates. But nonetheless, I think it just made a lot of common sense of like, okay, if you're first taking your baby home from the NICU, you should be pretty conscious about, any infectious exposure, including COVID-19. I will say we've had a number of patients with BPD who have had COVID-19. Some certainly get lower respiratory illness with it, like COVID-19 bronchiolitis, and require some support. We've had a lot of kids who've done quite well with it. We've had kids on oxygen who haven't even had to bump up their oxygen. So it's a very humbling illness, and I'm sometimes amazed by how these kids handle it. Again, there's a lot we don't know about it, so I tend to be very, I'm very cautious about not over-interpreting any of that, of course. But I say to parents, I sort of put that in the category of other viral illnesses. You wouldn't want your premature baby with BPD getting RSV. You wouldn't want them getting the flu. You wouldn't want them getting COVID-19. Common sense goes a long way as far as reducing infectious exposures, limiting the number of people they're around. I think in some ways, as society has kind of gotten used to some of the prevention of spread of viral illness around COVID-19, a lot of families of premature infants have basically said, well, I've been doing this since I took my baby home from the NICU. This is not new to me. And there's something to be said for now. There's sort of this very accepted thing, like, well, if you're having symptoms, don't show up to visit the baby and go see them. So, and sort of a more accepted, at least, I have a young baby at home who is premature. Can you wear a mask? Like, I think that, so, those are more accepted, nowadays, but, common sense goes a long way. The other thing, we just make sure parents realize the importance of is kind of creating the shell, if you will, around their baby. So we always say parents and any caregivers for the baby should be vaccinated against influenza. And babies can be vaccinated, of course, against influenza after 6 months as well. And then, nowadays they should be vaccinated against COVID-19 as well.
This is excellent. So I think, this is a great overview of COVID and kind of other viral risks that kiddos are likely to see, whether they have underlying lung disease or not. This patient specifically did have BPD and was actually on baseline oxygen. And in thinking about these patients long-term in the primary care setting, how quickly is oxygen weaned off? Does this predict long-term oxygen or respiratory outcomes, or they don't have asthma, or what other comorbidities are we going to see? How can we, what are we going to look at for the long term of these BPD kiddos?
Yeah, so specifically for the kids on oxygen, there's actually a number of ways of weaning that off. But in short, we usually kind of get kids off their daytime or awake oxygen first and then focus on the nighttime. Historically, we've kind of done in clinic weans or asked the parents to, monitor and give us reports at home just using the home monitors. Usually we could get kids down to about 1/8 of a liter and then, either go straight off or maybe do sprinting off. So you do an hour or two off at a time and then increase that over time. I think one of the more exciting things that we're participating in nowadays is actually using remote monitoring technology. So we actually can get reports from the patient's home oximeters and kind of look at where the distribution of oxygen trends are. And that actually allows us to wean the oxygen off more quickly than it does if we're just doing it based on clinic visits or, which can sometimes prolong the process. Historically, I've told families that on average, again, this is average, so there's a wide range, about 3-4 months. Again, I think we've been able to move that up quicker for some families, but we still have some kids. There are kids who need oxygen for, 12, 18, even 24 months sometimes.
And how about other comorbidities that are associated with some of the bronchopulmonary dysplasia?
Yeah, that's a really important question. I mentioned a few earlier. I always say to tell families like they're going to be part of this team, with a pediatrician and then the family at the center, of course, but, some of the respiratory comorbidities. So, early on, things like tracheobronchomalacia, which is airway collapse, vocal cord issues, so, other airway issues like subglottic stenosis. Long term, I mentioned earlier, asthma. We certainly know that these kids, if you do their PFTs, which is something that we do, so we like to follow these kids at least until sort of early school age, so they can do pulmonary function testing on them, higher risk of obstructive lung disease. That being said, they do very well overall, and I think actually, if you look at the long-term outcomes, there's it's probably, if anything, it's not quite necessarily the same as term kids, but still reassuring. The big question, which we just don't know, frankly, and I think this is one of the super interesting things about neonatology, is like, what does it mean for their overall life trajectory of lung disease, right? So even if you were to say, well, don't you have adults, that were born preterm, I'd say, yeah, I mean, there are studies that report 30 and 40-year-olds and what their lung function is. But, when were they born? They were born in the pre-surfactant, pre-antenatal steroid era. So I'm not even sure how much they apply to kids now. So this is something that we're going to constantly need to be studying, because as we change practices in neonatology, we don't know what those outcomes are for some time. Other comorbidities beyond the lungs. So pulmonary hypertension is one that's definitely worth mentioning, because that's probably one of the more important comorbidities to BPD. So that essentially is when there's right ventricular strain because of their lung disease. And the reason I mention it is that that's one of the comorbidities that's most associated with adverse outcomes and even more morbidity and mortality in these infants. So I think that's kind of when we see that, that's much higher risk. Those are kids who are going to be much more, we're going to wean their oxygen much more slowly, higher risk for readmission, etc. And they're closely followed by cardiologists. The lungs and the gut are like very connected. So a lot of these babies have issues with feeding, reflux, aspiration is a big one. So, I encourage particularly listeners going to pediatrics, if you have, babies who are born premature, you definitely want to be screening for, are there any symptoms or signs of aspiration, whether that be obvious or more silent aspiration, and sort of thinking about getting, speech language pathologists, SLPs involved where indicated. So they certainly need, these infants will often need nutritionists as part of their team because they're on higher calorie formulas and have higher risks of growth failure. And then, the other one is neurodevelopment, right? It's incredibly important that for these babies, and this is kind of the most important thing of all, right? This is why we do what we do, is to get their best, neurologic and developmental outcomes as possible. So, early intervention services make a huge difference and a huge impact in kind of, especially think about the plasticity of these infants early on. Many centers have neonatal follow-up clinics dedicated to assessing their neurodevelopment. And since we know that BPD and neurologic outcomes are so tied together, that's an important, we make sure that all these infants are plugged into those services as well.
One of the big things that is a major mission of our podcast and show is highlighting and showcasing racial disparities or social determinants of health. For kids that have bronchopulmonary dysplasia, can you talk about what some of the racial disparities are in taking these kids home, and what some of the challenges are from a health equity perspective?
Yeah, that's such a great question. And I think that's such an important piece to BPD outcomes, and frankly, something where there's a lot that we have to learn and a lot that we need to address there to improve these kids' outcomes. First of all, I say, just think about the burden in general for these kids. I always say, listen, it's hard taking any baby home. It's hard taking any premature baby home, and it's even harder to take a baby with, medical complexity and with BPD home. We work, I think many of these families are absolutely amazing and incredible in the dedication they have to their babies. As far as some of the racial disparities, there's actually a really interesting story with BPD that's kind of being told in the epidemiologic data. So, people might remember from their NICU rotations kind of comparing the respiratory outcomes, at least early on, of Caucasian and Black infants. And that's it's well documented. Infants born to Black mothers have lower risks of developing BPD than white infants who are, born at similar gestational ages. And that's despite the fact that because of risk factors for prematurity itself, there's more infants. Infants born to Black mothers tend to be at lower gestational ages, but still, even with that, if you look at large cohorts, have lower risks of BPD. That being said, once you have established BPD, the outcomes both in hospital and post-discharge of infants born to Black mothers are worse. So I think, specifically, what do I mean by that? It's in terms of respiratory hospitalization, higher odds of tracheostomy, longer length of stay. And I think there you have basically an effect in totally opposite directions. So that speaks to me to the fact that when you really look at the longer outcomes for these kids, not just what they're going to be at 36 weeks, it really highlights the lack of a biologically plausible explanation for those difference in outcomes due to race, because it's the effect is in opposite direction. And it clearly has to do with the social determinants of health and structural differences, right? So whether it's structural differences in the care that's provided in the NICU, is it that there's environmental impacts post-discharge, socioeconomic stresses, of course, that differ. I think there's a lot to be learned there about what drives those differences, and frankly, a lot to be addressed to improve the outcomes of these infants.
That's very helpful. That's fascinating and seems like a lot of opportunities for research in kind of better understanding the complexities of racial disparities in this care. This has been really wonderful. I feel like I wish I had this before my NICU rotation in residency. I think I would have felt much more prepared going in. I think yes. Dr. Nogi would have taken notice, and so this has been great. Are there main take home points that you think listeners should really walk away with in approaching BPD in either their training or in their patients that they're seeing in the clinic?
I'm glad to hear that you don't have too much PTSD from this podcast experience. Take home points. I think again, think of BPD as a disease of lung arrest. It's sort of interrupting lung development, and the best treatment we have, the best in some ways prevention we have, is going to be adequate time and growth to their lungs. And what we try to do is get these kids into this sort of pro-growth, pro-developmental stage overall, and certainly to their lungs in particular. So, avoiding noxious exposures like infections, aspiration, or other kind of inflammatory things that can be going on. I think another take-home point would be that, while this talk was about BPD, really all preterms are at risk for some of these adverse respiratory outcomes. And I think you guys pointed this out really nicely with the fact that BPD is like a 36-week diagnosis, but doesn't totally fit what these kids are going to look like after they leave the hospital. So, if you're a PCP or a hospitalist or any specialty, and you see a kid that has this history of being born in 8 weeks or 27 weeks, like our cases here, even if they don't necessarily have a discharge on oxygen or obvious BPD diagnosis, just think about that these kids are definitely at higher risk than, let's say, another full-term kid you might see. And the last thing I would mention is that BPD, again, it's ends up being a little bit of a catch-all diagnosis for kids with lung disease from prematurity, but we know that there are different phenotypes of it, and we touched upon this a bit, right? There's the kids who have more just their lungs are undergrown. There's kids who have more that obstructive, whether it's asthma or COPD-like phenotype. There's kids who have more of a cardiac piece, like the pulmonary hypertension. There's kids who have more like malacia and large airway issues. So, certainly when we're thinking about these kids, it's not a one-size-fits-all about how we approach them and the treatments that we would use for them.
Excellent. I think that's a great way to end it. I think before we let you go, we always ask, do you have anything you want to plug? Anything you want our listeners to check out? Something that you want everyone to know about?
So we in Boston, we're very proud to be part of this international BPD collaborative, which has been growing quickly. There's almost 30 centers now, probably more by the time people actually listen to the podcast. But it's of centers who are really taking interest in improving the care of kids with BPD and, both the clinical care, doing research, kind of putting together large registries of these kids. So I think that's just going to be a really exciting area where a lot of what we talked about before, how there's a lot we don't know because we don't have, whether it's trials or looking at some of the epidemiology or social determinants of health, that's, I think, going to be very promising in cross institutions to be able to look at that and improve care of these infants.
Excellent. Well, thank you again for spending this wonderful night. Justin said that we learned a whole bunch, and I really, really wish that I could turn back time and had listened to this episode before my NICU times, but we will pass it forward, and hopefully all our listeners now will be able to enjoy the fruits of the labor tonight.
All right. Well, thank you guys. It was really a pleasure and an honor to do this with you guys. So I appreciate Tess, Justin, and Chris. I appreciate it a lot.
Thank you so much for your time and expertise. We really appreciate it.
This has been another episode of the Cribsiders.
It's for the kids.
You can get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We are committed to providing you with high-value practice change and knowledge, and to do that, we need your feedback. So please subscribe, rate, review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com, or just tell a friend to come listen. We'd love to have him. A special thanks to our producer for the episode, Dr. Kes Curran, also Dr. Shannon Snellgrove, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. Thank you for joining us. I've been Justin Lee Burke.
I've been Tess Curran.
And this has been Chris, the Chi Man Chew. Thank you and good night. See y'all.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.